practice at the Pediatric Center in Stone Mountain, Georgia. He is a fellow both of the American Academy of Pediatrics and the Society of Adolescent Medicine. He has served as the chair of the policy committee for the Academy's Steering Committee on Clinical Information Technology, now the Council on Clinical Information Technology, on the Academy's Committee on Adolescents, and as the past chair of the Georgia AAP Chapter's Committee on Adolescents. The American Academy of Pediatrics is a professional organization of pediatricians with more than 60,000 members trained to deal with the medical care of infants, children, and adolescents, and we welcome you today to this committee, sir.
Welcome.
Thank you very much, Madam Chairman Velasquez, Ranking Member Mr. Chabot, and members of the committee. I'm honored to represent the American Academy of Pediatrics before you. My name is Edward Gotlieb. I'm a practicing physician, pediatrician in Stone Mountain, Georgia, and you've heard my credentials. Let me tell you about pediatrics. 60% of pediatricians practice in small businesses. Pediatricians are asked by industry to pay extra for electronic health capabilities to deal with the complexities of pediatric care, yet we're reimbursed by the government less well to provide these services than our adult care colleagues. Let me explain. Pediatricians are different from other doctors because the major government program that pays for the health care of children is Medicaid, not Medicare. Medicaid has a major impact on children's care, paying for 40% of births in the United States, and I believe 60% in Georgia. Medicaid faces fiscal problems, but not because of the more than 30 million children that are covered by the program. These children account for more than 50% of Medicaid's population, but only 25% of its cost. Pediatricians find it very costly to purchase health information systems. A real factor in our inability to afford these expensive technologies is the payment rates that pediatricians receive under Medicaid. Under Medicaid, payments for providing the same medical services average 69% of what Medicare pays. So the margins under which most pediatricians' practices operate are much more severe than those of our adult colleagues. Furthermore, if incentives for adopting health information technology are structured to flow through the Medicare program, as is now largely the case, more than 60,000 practicing pediatricians would be excluded from the opportunity to qualify for these incentives. The already inequitable system of funding programs for children will only be worsened. This is not a good investment in our future. Unfortunately, even if we do receive help to adopt health information systems in our practices, we face special constraints because of special needs of child care and the rules governing privacy for our patient population. Electronic health records are frequently designed for adult care and do not take into account the specific needs of children. There are a number of special functions that a pediatric health record requires that must be implemented in an electronic health record. In their absence, we pediatricians are hampered in our ability to properly document care. Yet the vendor community frequently asks us pediatricians to pay extra for these capabilities, even if they're willing to provide them at all. Major areas in which these needs arise are in immunization documentation, immunization registry management, growth tracking, medication dosing, privacy for special pediatric populations, and in providing normative data by age, body mass index, or developmental stage. Of particular concern in today's discussion of health information technology incentives are adolescent privacy concerns. The HIPAA privacy rule and its implementing regulations defer to the state and other applicable law on the issue of adolescent privacy. Laws about age of consent vary from state to state and according to the patient's presenting problem. The electronic health records need to be able to reflect this. As an example, in many states, adolescents who present for the outpatient treatment of mental health disorders may consent to their own treatment before they become 18 years old. Pediatric practices typically have policies with respect to what portion of an adolescent's care should be handled with special privacy protections. EHR should be flexible enough to handle these practice-level policies. The recording of patient and parental consent child assent, and the permission to treat are frequently less straightforward for children and adolescents than for the care of adults. The separation of the patient's consent and the parent's or guardian's consent is particularly important in the areas of testing for drugs, screening for sexually transmitted illness, or in the case of abuse. Remember also that our privacy concerns are not limited to minors. We pediatricians continue to care for young people through age 21 and in some cases beyond. My written testimony also focuses on other special cases, children in foster or custodial care, consent by proxy, adoption, guardianship, and emergency treatment. Thank you for the opportunity to testify